We can see in this Journal of American Medical Association network the process of deprescribing. If a patient is receiving multiple medication, we need to think about whether these medications are of benefit to the patient. Are these giving the patient benefit over harm? Are they controlling the symptoms of the disease? Are they having any preventative measure? If none of these factors are fulfilled, then seriously we should think of stopping these medication. And stopping these medication will go into two phases. First, we will stop the medication, look for stability of the symptoms, and if the symptoms reappear, we can taper the medication and then reassess the patient condition, and safely we can discontinue the medication. Otherwise, we can restart the drug therapy whenever there will be a necessity out of those factors. So what are the take-home messages from this talk? Number one, polypharmacy is the use of more than 5 medications by the same patient. Polypharmacy is usually associated with increased risk of death, increased risk for hospitalization, and increased risk of drug-to-drug interactions. The aging is associated with physiological changes, which leads to changes in pharmacokinetics and pharmacodynamics of medications. Managing drug therapy in the elderly patient is often problematic because of lack of evidence on which to base prescribing decisions. Explicit and implicit criteria are available to guide appropriate prescribing. Prescribing cascade should always be considered in the setting of new medication side effects. And deprescription is a very important process that is associated with improved clinical outcomes. You can find more resources in these links, and thank you very much for allowing me to give you this presentation.